All right, we might get going now. Thanks everyone for joining us this afternoon. I'm Yvonne Zarinsky. I'm the Associate Professor of Health System Sustainability at the Australian Institute of Health Innovation, Macquarie University. And I co-lead the Observatory for Health System Sustainability under the NHMRC Partnership Centre for Health System Sustainability. And today we're talking about realist evaluation of a research translation program, and we have some fantastic speakers from Western Australia. But before we get started, my screen is not advancing for some reason. Here we go. I would like to do an acknowledgement of country. We acknowledge the traditional custodians of the land on which Macquarie University is situated, the Wallumattagal people of the Darug Nation, whose cultures and customs have nurtured and continue to nurture this land since the Dreamtime. We acknowledge the traditional custodians of the various lands on which you all join today, and the Aboriginal and Torres Strait Islander people participating in this webinar. We pay our respects to elders past, present, and emerging. So before we get started with our guest speakers, I'd just like to give you a little bit of an overview of the NHMRC Partnership Centre for Health System Sustainability. We are a large centre funded by the NHMRC with 5 funding partners, so Bupa Health Foundation, the Department of Health Western Australia, University of Notre Dame, New South Wales Health, and of course the NHMRC, and we commenced in January 2018. We're quite a large centre. There are 17 lead investigators, 7 research leads, 6 system lead investigators, 4 designated system-based investigators, over 20 expert advisors, and over 40 system implementation partners from around the country. We are a national centre and we cover all of Australia. We are governed by a governance authority, which is composed of our funding partners. We have a scientific advisory group as well as an international advisory group. And our purpose is to investigate, study, and create interventions to improve health system performance sustainability, with the vision of actually our research findings having a significant influence in the development of a resilient healthcare system that is affordable, cost-effective, and delivers improved health outcomes for all Australians. Our objectives are to synthesize and disseminate existing research relevant to improving health and healthcare system performance, undertake collaborative new research, and we certainly do a lot of that, including cross-sectional, interdisciplinary, and transnational research. We also want to build capacity within the research community to conduct applied research and within the system to use research as part of change management, and also to support implementation of research-informed changes in health and healthcare systems. So we have 3 streams: analytics, technology, and shared data, reduced waste and low-value care, better value for the health dollar. And this is supported, or there's a cross-stream which includes the admin team and focuses on system evaluation and system change. And that's underpinned by the central unit, which is located at Macquarie University, and we've named ourselves the Observatory on Health System Sustainability. Our networks have grown significantly since we started, and as you can see here in the sociograms, and we believe our networks will keep growing even after the end of the current funding round. So this is just a little bit of a summary of the PCHSS in numbers. We have 52 collaborating institutions, 656 peer-reviewed publications, 798 conference presentations, and over 1,000 media engagements. And I want to say thank you to Genevieve and to Kaylin for keeping abreast of these numbers. It's quite important to have that, and a huge achievement. We have also attracted $126 million in leveraged funds. So I will stop sharing now and introduce you to our first speaker, who is Professor S.S. Vasan. Vasan is the WA Department of Health's Director of Medical Research and Innovation, previously the CSIRO's COVID-19 science leader, who has also worked for the Health Protection Agency, Public Health England, and the NHS as Customer Delivery Director for Hampshire. A former McKinsey consultant and Rhodes Scholar, he has a doctorate from Oxford and an honorary chair in health sciences at York. And today, Vasan will be speaking about the research, translation, and health systems sustainability. Welcome, Vasan. Thank you so much.
Hi, thank you very much. Can you hear me well and see my slides well?
Yes, perfect. Yeah. Thank you.
So I will be brief and set the scene by talking about the Future Health Research and Innovation Fund. The FHRI is the Western Australian equivalent of the MRFF, loosely speaking. And we will just go through my office, which was previously called the Research and Innovation Office, just before my appointment and as part of the restructuring here. From this financial year, we were renamed as the Office of Medical Research and Innovation, coming directly under the Deputy Director General, Angela Kelly. So the sort of arrows that flow into my office essentially denotes the funding. So we have funding worth roughly about 10 million or so coming from the Department of Health, and then from the Future Health Research and Innovation Fund, approximately 30 million. So approximately around 40 million, and that changes year on year. The outputs from my office are around research, data ethics, and governance. And then we are increasingly focused on the I bit, which is the innovation bit. So this is intellectual property and commercialization and translation of research to benefit the people who ultimately pay our salaries. The Sustainable Health Review, which was first published in April 2019, so that was kind of when I moved to Australia from the UK, but to CSIRO. There are two recommendations in there, 28 and 29, which sit under Strategy 8. These numbers may not mean much to you, but essentially what I wanted to say is that there is a specific recommendation and a mandate to report on medical research and innovation. The focus, of course, is on prevention, equity of access, from early child health to end-of-life care, ensuring there is a seamless access to services, both at home and in the community. Now, you might probably know this already. There are two facts which are very interesting to me. We have, under a single health authority in Western Australia, the largest land area, 2.5 million square kilometer, anywhere in the world. So on one hand, you have urban, one of the fastest growing cities in the world, Perth, and the greater Perth region, where about 78% of the population lives. But you also have the remaining 22% split into small communities. So for us, remote health, aboriginal health, rural health is as challenging as delivering the urban health priorities, right? So that's one. And the other is, we started off in 1850 on January the 1st as the medical department, and through a succession of name changes, are currently the Department of Health. But we are only one of, depending on how you count, 8 or 9 different independent legal entities that form WA Health. So you have the different health service providers with whom we have to work to help deliver these health review recommendations. So the little bit more on the strategy 8, innovate for sustainability. The important bits here is partnerships. Again, we will be talking about RTP. So setting the scene here is the partnership between clinicians, consumers, and external partners to develop, test, and spread the initiatives for better patient care and value. Having a more open approach to experimentation and a culture that underpins innovation at horizons 1, 2, and 3. So ranging from sort of routine operational innovations in horizon 1 through to blue sky research in horizon 3. And ensuring that these are linked to the priorities of the health system and embedded and supported by the FHRI fund, which is the Western Australian equivalent of the MRFF. So there is an act of parliament which governs this fund. So its main goals are to improve financial sustainability of the WA health system, improve the health and well-being, both physical and mental health. So not forgetting parity of esteem, ensuring wealth creation for WA and our position as a leader in research and innovation. So this is the fund website that you can Google. The FHRI is the sovereign wealth fund of WA, repurposed towards medical research and innovation. So the funding principles are many, but some of the important bits are around accelerating, translating, and ensuring sustainability. But to do all that, we come to the 8th bit, which is relevant to this meeting, which is how do we review and evaluate the performance of the fund in terms of at least 13 different programs that we offer. Some may not continue, but there will be others that we start. So it's continuously juggling the priorities of changing healthcare needs. And of course, COVID has come and disrupted a lot of that as well. So, and long COVID and living with COVID strategy of the Department of Health at the moment. The programs are essentially for translation built into the design of all of them. And how do we facilitate the translation into policy and practice and identify the gaps in implementation to benefit ultimately the people. So one of the umbrella programs under the FHRI fund is called the Research Translation Program, also confusingly abbreviated as RTP, but sat within that is the Research Translation Projects, the Implementation Science Fellowships and Translation Fellowships, which are focused around mental health and Aboriginal or country or regional health. And again, I set the context to you as to why that is important earlier. And the RTPs, which we will spend the next few minutes left on, was established in 2007 to support research projects which show potential to demonstrate improved cost effectiveness or efficiencies within the system, and to be translated into improved healthcare policy and practice. So the aim for us is to enhance the quality and sustainability of the delivery. And we awarded approximately 10 projects worth about 2.3 million. It's currently on hold pending outcomes of evaluation, and I'm hoping that if it's positive, we can make the case to the Funds Advisory Council to continue. So as one example I put in, which was in the news recently, so 1.3 million people die from resistant infections of bacteria, and there was a discovery here which showed, that we can detect the infection in hours rather than days and identify effective antibiotic treatment. So AMR, as you know, is a very big priority for the nation and globally, and it's no different for us in WA. Finally, this particular partnership center is something that we are obviously very interested in to support and participate in terms of translation of research being crucial to the sustainability of the health system. So people like me, looking at 30 plus 10, 40 million of funding, we need to understand year on year there is this money available, and we are designing funding programs, but we have to do so in a way that can enable translation of research that benefits people. And we need to understand how and why or why not certain designs work and others don't. There is an opportunity cost of what I fund. If we fund cancer, that's money we have not spent on cardiovascular or mental health. So it's really important to understand that in a funding constrained healthcare system such as Australia and indeed the UK, US, etc., the opportunity cost of funding is really important, and cost effectiveness studies go a long way in understanding whether the incremental cost effectiveness ratio, how does that compare, in terms of the QALYs gained or DALYs averted with regard to a particular intervention, and how much did it cost us to, implement that intervention. So in partnership with the NHMRC Center, we are hoping to have our RTP programs evaluated. So that's my email. If you want to get in touch with me, I'll be happy to answer offline, as well as, if time permits, any questions. Thank you.
Thank you so much, Vasan, for explaining the WA research translation programs. It's really exciting what's happening in Western Australia, and we look forward to hearing more about it. If you could stop sharing, Vasan, I'll introduce our next speakers. I just want to mention that if there are any questions from the audience, please put them into the Q&A. And hopefully we will have some time at the end of this webinar to actually have a discussion and answer some questions. But now I'd like to introduce the next two speakers. They're doing a double act. So Delia Hendry is a health economist and teaching research academic at the School of Population Health at Curtin University in Perth. She participates in both research-driven and demand-driven research across several program areas relating to the economics of health service organisation and service delivery, and the effectiveness and cost-effectiveness of healthcare interventions. She has authored multiple peer-reviewed scientific papers and presented at many national and international conferences, and her contributions have earned recognition from experts around the world. So welcome, Delia. And joining Delia will be Abby Mosedale. Abby holds a teaching focused position at Curtin University in the School of Population Health. She has a master's degree in health administration from Curtin University, as well as a Bachelor of Nursing, and has experience in critical care. So, and Abby is a PhD candidate with a special interest in the complexity of health system sustainability, research translation, and realist evaluation, which is a very challenging area, a very interesting PhD. And we're really looking forward to hearing from Delia and Abby. So I'll hand over to Delia now.
Thanks very much, Yvonne. Abby is, we're in a different place, so Abby is driving the slides. So Abby, could you please share the slides, and I'll just sort of say next slide when I need it. So this is sort of a twin presentation. I'm just going to give an introduction to both the research translation program, which Vasan has done some of that, but just add a few extra points. And then also just in terms of providing some background in terms of evaluation approaches. Abby, next slide, please. So the research translation program, or just the project part of the program that we're evaluating, it's very similar to many other funding research programs in terms of it's competitive. And Vasan has pointed out, its purpose. It's ultimately just to improve healthcare practice and policy, wanting to improve patient outcomes. It funds across a lot of different areas: clinical research, health services research, public health research. And as most research funding is nowadays, it represents collaboration between practitioners, clinicians, researchers, and consumers as well. What's different, a bit different about the Research Translation Project Program is that one of the funding criteria, so in order to get funding, the application must show that it's potentially, it can potentially achieve cost savings while not compromising patient outcomes. So that sort of set it aside a bit from many other funding programs. And those efficiencies can be generated in different ways. It can be generated through, say, workforce changes, say task substitution. It can be generated through adoption of new technology. It can be, they can be achieved through eliminating low-value care, avoidable hospitalizations, and so on. So that sort of sets it aside a bit. And also because we're at the other end of the nullarbor here, we're a bit sensitive about not getting our fair share of research funding, the national competitive research funding. And so one of the purposes when the fund was first established, or the program was first established, was so that researchers here could gain more experience in terms of we could use the work we did within the RTP program as sort of pilot work to support nationally competitive funds. It was also part of capacity building as well. But so similarities and differences to other research funding programs, but in general, I think the findings of this particular evaluation will have a wider application across other research translation programs too. Next slide, thanks, Abby. So the question was then how to assess the value of funding health research. I mean, Vasan has pointed out how important it is. There's an opportunity cost to funding anything, and that's what you forgo by not funding other things. And so obviously, in Australia, we're not sort of known for being at the forefront of R&D just generally. But the most recent figures from the Australian Institute of Health and Welfare suggest we're spending about $6+ billion on health and medical research. So obviously we want to evaluate it. And while there's a lot of different evaluations are done in a lot of different ways, the two main approaches are either to use some kind of evaluation framework, and it typically has some time dimension, sort of what can we achieve in the short, mid, and long term. And then also within those dimensions, there are some performance-related dimensions. So that's the one approach that's used quite widely. And then the second approach is to estimate, to do some return on investment measures. So I'll just briefly speak about each of those in turn. Next slide. So the framework indicator approach, that draws very strongly from the logic framework approach that's used widely to support project planning and management. And I'm sure you're all very familiar with this. And so, for example, the NHMRC evaluation strategy, their logic model, their evaluation strategy was released, I think it was at the end of last year. And so that's a matter of, what's the inputs, the funding, and then what's being done with the funding, and then what's the outputs of the funding, and then what's that leading to outcomes, what change in practice, and then lastly, the impacts in terms of actual health outcomes, and then the other outcomes. Vasan spoke about things like commercialization, for example. And so just in terms of how they tend to work, I think in 2017, there was a systematic review done of evaluation frameworks. And they came up with a kind of this model, which is shown on the bottom right-hand side of the slide. And what this shows is that you've got your short, mid, and long-term dimensions. And so the short-term dimensions are just those research-related ones in terms of outputs, dissemination, capacity building, and so on. The midterm ones are, is the research influencing policy and practice? And then the longer term ones are moving on to the extent to which that's improving quality of healthcare, service delivery, better information in the system, is that influencing health outcomes? And then they're the longer term ones in terms of some of the economic outcomes as well. So this kind of evaluation framework approach, it sort of builds on work that Buxton and Haney did in their payback model, and then many other people did as well, and perhaps more recently the Canadian Academy of Health Sciences model. Next slide. So the other approach is the return on investment approach. And those of you who are economists would know that with these return on investment approaches, it draws on economics. So it's a matter of, are the benefits that we're achieving from our expenditure, are they worth the cost that we're paying for that? And so I've just taken a fairly recent example here. It was done by KPMG. It was a commissioned piece of research looking at the economic impact of medical research in Australia. And what these return on investment approaches try to do is they try and look at the long-term, the long-term benefits of investing in research. And the way that the KPMG did this one is that they did some case studies and they generalized from there. But if anyone's done any of these before, they're just very data driven. They're very data heavy. And because you're projecting into the longer term and trying to work out, for example, what are the benefits through commercialization? What are the benefits through a more productive workforce, creation of jobs, and all those kind of factors? And then also the other thing is that you have to monetize all the health benefits as well. So, you know, if you're reducing morbidity or preventing mortality, you've got to put that into monetary terms. And so, you know, there are a lot of assumptions that go behind this kind of evaluation of your research funding. What they found in this particular case, you can see there, they got benefit cost ratios of 3.9 to 1, meaning that for every $1 that is being invested in research, it's providing $3.90 of benefits. Next slide, please. So we had the question of, we were given the task of doing an evaluation of the RTP program. And obviously the health department, I mean, for accountability reasons, there is reporting back to WA Health. And so they've used the traditional methods, the evaluation framework method, looking at some of the short-term indicators. And in fact, Abby, in her PhD work, she has actually done a full, well, not a full, but a short and midterm evaluation framework evaluation of the RTP program. So that's sort of the prior programs. And they had actually done 1 or 2 efforts had been made to use return on investment, specifically relating to 1 or 2 projects. But I guess what made us rethink the best approach to evaluating the RTP program was the evaluation was being conducted as part of the evaluation, the Partnership Center for Health System Sustainability. So, you know, we wanting to link the research funding to actual sustainability. And we were asked in the agreement we have with the Partnership Center, the brief is to look at the system-wide impact of the program and its potential to transform the health system practices. And also not just to look at the system level effects, but also to look at what are the mechanisms or processes through which these effects occur. And then what are the characteristics? Because some projects, you know, as is always the case with funding research, some work really well and some work kind of less well and some don't kind of work at all. And so it's a matter of what are the characteristics of projects and those contextual factors that enhance the likelihood of achieving positive system level effects. And then there was also the additional issue that, WA had the sustainable health review that Vasan spoke about that reported back in 2019. So we wanted to sort of fit within that context as well. And so rather than, I guess, maybe try and do some assumption-driven return investment analysis, or perhaps do more in terms of using more investigation using an evaluation framework approach, which, as I said, Abby's done already. We thought, well, this is a really tricky, good research topic for a PhD candidate. And that PhD candidate is Abby, and I'll hand over to Abby now.
Thanks, Delia. You are correct that it is a tricky project for a PhD candidate. I'm just trying to transition my slides here, but having a bit of trouble. There we go. So, yeah, thank you, Yvonne and Delia and Vasan. So as Delia mentioned, excuse me, this is a piece of research that's contributing to my PhD thesis. So I am coming at the methods of realist evaluation as a novice. So first of all, please bear with me. But also I think that's given me quite a unique opportunity to identify some of the challenges, but also some of the value for conducting realist evaluation or using the realist methodology. Because I've had to really build up that knowledge from the ground up. So I hope to share some of those with you all today. So just a quick overview of my presentation. So I'm just going to touch on some of the principles of realist evaluation. I don't want it to be a lecture about the methods of realist evaluation because we will be here all day. So looking at the context mechanism outcome configuration, which is core to the realist evaluation analysis. A little bit around realist evaluation cycle, and then the value of realist evaluation and how we've applied that to understanding research translation in the WA healthcare system. So I'll also touch on a few of my preliminary results. As I talk through, it'll become clear that realist evaluation is quite an iterative process, and so these preliminary results are obviously still we're still in the process of doing some analysis, but the purpose of me presenting these results is more to show how the realist approach has been applied and some of the benefits of the results and the benefits to decision makers that we get from this realist approach. So for those of you who don't know a lot about realist evaluation, this little slide here, this little cartoon here is not an indication of my incompetence as a PhD student. So she is not going to tell you whether or not a program, she's not going to tell you that a program works or not. It's actually, that is a core fundamental to realist evaluation, and I'll explore that a little bit more now. So the principles of realist methodology, it's a form of theory-driven evaluation, and it's underpinned by the philosophy of scientific realism. So I'm not going to go into scientific realism and generative causation and lots of terms that need explaining. There's lots of resources out there to explore that further. But what I want to focus on is the questions that realist evaluation attempts to answer. And it's based around this idea of what works for whom and under what circumstances. And that's the realist tagline. I don't think there's a published realist evaluation paper or protocol out there without that tagline. So this is different to some of the approaches that Delia spoke about earlier around that look more to identify whether an intervention or a program works. So it's more about the how does something work rather than does it or does it not work. And so this idea of what works for whom and under what circumstances is closely linked to context mechanism and outcome configuration, which you'll also see a lot in the realist evaluation literature. It really underpins the philosophy behind realist evaluation. So there's the idea that intervention X will achieve outcomes Y only within a particular context that triggers a mechanism. So just to explore that a little bit more, a context can include social, cultural conditions, social norms, or rules, values, and interrelationships around the program. And then within that context, certain contexts will trigger mechanisms which are explanations of why participants make certain choices. They're often invisible, and it's really just that explanation of how we get from X to Y. And then obviously outcomes there are pretty self-explanatory. So context, mechanism, outcome. The mechanism is really the combination of context and mechanism is really the black box of interventions. So we know that X leads to Y. Well, how does that happen? And why does that happen differently in some settings and differently in another, or for different populations? So very quickly, I just want to touch on the realist evaluation cycle. So the methods that sit behind the realist evaluation approach, or the realist approach. A big part of realist research is that it is methods neutral. So it's almost a bit more of an evaluation framework, for lack of a better word, which makes it really difficult as a PhD student. I'll discuss that a little bit more later. In general, there is this cycle of, or this iterative process of beginning with your research question and formulating an initial program theory. So without getting too technical, this theory is a theory of how an intervention is intended to achieve its outcomes. So often interventions and programs, particularly complex interventions and programs, such as research translation or funding for research translation, they kind of are they're theory-based. So they may have been thought up in the minds of managers, policymakers, with some evidence to support them, but the theory behind how they will achieve their outcomes isn't necessarily explicit. So the idea of formulating that initial middle range theory is to make that theory explicit, which then forms the basis for the evaluation, or the framework for evaluation. So moving on to data collection and data analysis using the context, mechanism, outcome configuration. Synthesis, so translating that into, or articulating that into a theory, which can then be refined and tested. So it is an iterative cycle of this building theory, testing theory, and then refining theory. This slide is very similar to the previous, so I'm not going to go into it in too much detail because I am conscious of the time, and I'd rather get to the application of the realist evaluation process. So I'm just going to move on to this next slide. So what does realist evaluation have to offer? So as I said at the beginning of this presentation, it asks how does an intervention work rather than does an intervention work? And I think that provides really useful information for policymakers or intervention custodians, managers, so decision makers, to then strengthen interventions. So through calibration and customization of interventions to the local context. And this is where I think it feeds in really nicely to intervention sustainability, but also to that broader health system sustainability that Vasan and Delia have already spoken about, in terms of just rather than, I guess, disinvesting in interventions or letting them fall by the wayside, we can really try to strengthen them and make them work harder for the health system as a whole. So, and obviously there is value in the evidence that's produced from research, from realist evaluation in the design for future interventions. So onto the project that I'm working on with Delia, excuse me. So we are looking at the Research Translation Projects Program, and as Vasan said, that is a very unfortunate name with the two Ps. But so we're trying to identify the mechanisms or processes through which the effects of the Research Translation Program occur, and also the characteristics of projects and contextual factors, mainly, that enhance the likelihood of a positive system level effect. So far, what have we learned about research translation and the RTP program, and how did realist evaluation help us get there? So we have some results, and as Delia mentioned, I have undertaken an evaluation of the program using that traditional research translation framework approach. But from the Realist Evaluation part of the project, a big kind of, I want to say, realization that has fed into this process of Realist evaluation is that research translation is a social process, and Realist evaluation is really valuable in that sense because it does look at the interrelationships of actors in the system. And so framing it in that social process window really has helped us to understand the RTP program and some of the mechanisms that are at play. So we've conducted interviews with stakeholders. I've looked at, we've done some thematic analysis of program documentation and the literature. We've identified multiple intended and unintended outcomes of the RTP program and multiple mechanisms or potential mechanisms that are at play. I mentioned before it's an iterative process, which means that we're still conducting some of the analysis, and that iterative process, and I'll talk about this at the end of some of the challenges, can be a real challenge with the Realist evaluation approach. You can tend to get lost in some of the context mechanism, the heuristic tool that we use. It can be quite difficult to distinguish between the different components of the CMO configurations. So one hypothesis and some initial testing that we've done, I'm going to go through just to demonstrate how the Realist approach can be applied to better understand an intervention and form strategies to strengthen the intervention, such as the Research Translation Projects program. So just to begin with, at the top there in that pinky red oval shape, we have collaborative research between clinicians and academics. And this is the activity in which that is produced by the RTP program. So it's the intervention, if you like. And that intervention aims to achieve decision for implementation or organisational action. And so the RTP program is aimed at producing evidence for implementation rather than solely just for implementation. It's more about that evidence that is able to then be used by decision makers to make a decision about implementation going forward. So collaborative research leads to decision for implementation and organisational action, and it does that through these mechanisms. So through capacity and relationship building. So there's an academic capacity that researchers bring to the team, and there's clinician capacity that clinicians bring to the team. And through the relationship between the members of the team on the academic and clinical side, we have an exchange of knowledge and skills. And that enables, or that leads to the formation of evidence for implementation. So evidence that aligns with decision makers or decision makers' attitudes and values based on issues that evidence addresses. So it's about the credibility and the usability of that evidence that's produced by the team. So they are the mechanisms. And then we've identified some contexts in which need to be in place for these mechanisms to be triggered to lead to evidence that is usable for implementation. So some of these, the context is around pre-existing attitudes, past experience and staff turnover. So pre-existing attitudes is things like an attitude towards research. So clinicians come in with certain attitudes towards research and academics, and I think we're all pretty familiar with sometimes that gap between our approach and our values around research, that gap between academics and clinicians. Then for that second mechanism of evidence for implementation, the nature and the topic of evidence produced is really important. So if the nature and the topic of the evidence or the project isn't aligned with the decision makers' values of issues, important issues, then we won't see that mechanism triggered. And then the final context is around kind of your political agendas and resources. So a bit more external to, say, the setting in which the project is taking place. So when we've had some initial analysis or testing of this theory against RTP, so just talking to some stakeholders and past participants in the project, we have identified that while a lot of the relationships and the teams work very well together, there are some instances where existing attitudes or values towards research mean that this capacity building mechanism isn't triggered as well, or it's not as strong as it is in others. And that then has a flow-on effect. And we've also noticed that the nature of the topic and evidence produced may not align with the decision makers' priorities. And I think that's a really important one going forward, and whether or not one of the strategies for RTP is to bring managers or decision makers on board into the research team more fully than they already are. And then finally, if there is a political agenda that doesn't fit with the information that's produced through this research, then obviously it doesn't lead to an outcome of implementation. So this is a very brief and watered down version of some of the analysis that we've done and the results that we've got. But I think it's important just to demonstrate the usefulness of the information that we get from taking a realist approach. So just some RTP program strategies that we may be then be able to recommend on using that evidence is that decision makers are part of the team to ensure you have buy-in, collaboration at the application process to be strengthened. There is evidence that the health economist is brought onto the project days before the application is due, and then they don't have that opportunity to share their professional expertise, and the project starts off on the back foot, if you like. Political foresight and contingency planning may be part of the application process. And so I think what this demonstrates is that solutions or strategies to strengthen this program actually go beyond funding for implementation. So a lot of people have spoken when talking to stakeholders that the RTP program needs continual funding for the actual implementation of strategies that they've evidenced. But I think there are other strategies other than just funding that can be used to strengthen the program and to see that implementation and then sustainability of the interventions going forward. So just very quickly, I'm conscious of time. So what I've learned from this realist evaluation process, there's lots of different aspects to be fully understood when you take on a realist evaluation approach. I think in terms of concepts, there's been a lot of learning around research translation, collaborative research, sustainability, intervention sustainability. So I think taking it on, it's important to have a good understanding of the literature around concepts and theories. It's methods neutral, which is a plus and minus. It gives you a bit of creative license, for want of a better word, to adapt to your research question, but also it means that, and I don't know if this is just unique to being a PhD student, but there's no script that you can really follow in terms of analysis, which does make it a little bit difficult. It's iterative, and that can be time consuming. I think it is really valuable for decision making and brings a new perspective. It brings evidence that's actually usable for decision making, and it makes our evidence or our evaluation almost work harder for the system. Has value for implementation and intervention development, and I think also has value for health system sustainability, in that you're getting a bit more return on investment for your research. And so I think I will leave it there, some references for you, and I'll just turn my mic off and stop sharing my screen.
Thank you very much, Abby and Delia and Vasan. That was fascinating and a really challenging approach to evaluation of a translational research program. If there are any questions, please put them into the Q&A. Abby, it was really interesting. Everyone, please turn your cameras on because we do want to have a bit of a discussion about this. Abby, it was really interesting to hear about the importance of context. But of course, as we know, the contexts in healthcare change all the time. So can you comment on that and how that actually plays into the program theory development?
Well, it's a challenging question. I think the nature of realist evaluation is that it's theory-based. So potentially you are building theories or contingencies. So you're not just identifying one context, you're identifying a lot of different contexts that may impact on the intervention or may trigger different mechanisms. I don't know, does that answer your question? I think then you can, it almost gives you a little bit of foresight when that context does change.
I was just getting at the iterative nature of the evaluation and how you may need to actually adjust your program theory as contexts change.
Yes, definitely. And that is a big part of the realist evaluation approach, is that it is pragmatic as well. And so I think that is important. You can use it as a framework, but definitely if you continue to do evaluation using that realist evaluation framework for the same program, then yes, working in different contexts and adjusting your program theory as you go is important.
I may just add to that, if that's okay, Yvonne. It's just, and we haven't, Abby didn't mention it, and it's because we haven't got to that stage of the research yet. But we are, because there's so many contexts and mechanisms and these can change over time, we are planning that the program theory will be built into a causal loop diagram, systems design. And what that means then is that the context may change. And so the mechanism of getting from, of getting the outcome or the X affecting Y, one mechanism may change because the context changes, but that doesn't mean to say, oh, there are not other mechanisms that can kick in that could also lead to X leading to Y. I haven't explained that very well, but I think it's just to try and explain that it's not a linear process like maybe the slide reflected, that you've got A plus B equals C. It's much more complex than that, as you know only too well. Yes, and so I think by representing it more as like a causal loop diagram, that you have all these interactions taking place, and you get positive and negative, like you got the reinforcing and the blocking that takes place. So I just thought I'd add that. Hopefully we get to that stage.
I think you're right, Julia, and I didn't mention that. I'm sorry. It's a misrepresentation, that linear diagram. It's definitely a lot more complex than that, and often contexts become mechanisms and mechanisms become contexts, which also adds another layer of difficulty to the process.
I think right now Abby is just totally lost in context mechanism outcomes.
I dream about it at night. Yeah.
Thank you. Vasan, I wonder if you could comment on the potential usefulness of this approach to a funder like yourself.
Well, I haven't seen the final report from Delia. So, I mean, there were people. So, if you look at implementation science as a discipline, interdiscipline, particularly within public health, you had the first textbook come out a few years ago by Trish Greenhug, and if I remember, she also wrote about it way back in 2005 or something. Before she moved to Oxford, she was, in London, and so this goes back some time, I mean, I would be keen to see, I mean, Abby flicked through her references slide very, very quickly, but I don't mind seeing it again. But it's an old wine in new bottle. It's making a comeback. I mean, apart from many things I do, I also have taught health economics and a particular interest in health technology assessment. It's a real numbers game for us. So it's not a joke. It's there are questions that could be asked in the parliament or by freedom of information or other ways. Not that I encourage you to do that, but I think it's really important to have that. We have a fiduciary duty to the taxpayer, that from where ultimately these money comes from, and to demonstrate that we have adequately considered the opportunity cost of not investing in a different program. And you have constantly people going to the government and asking for a lot of cash with only for their own programs to the exclusion of the others. And this is a perpetual dilemma. I'm no fan of converting, putting a value on life, as it were. If you think about it, that's what it comes down to. Delia was alluding to it. Effectively, when you are taking DALYs averted or QALYs gained, and then you do all this malarkey that people do to muck around with GDP and our PPP adjusted GDP, and you end up with a very complex scenario as to what that means. This is not to say that those methods do have their utility. I think there was that KPMG thing that Delia showed, and they have some limited ability. If you're funding a program which is largely a state program or a national program, and you are trying to compare two different programs, and they are both only applicable, say, to a particular state or a particular population group, then that's okay, because you're not really putting a value on life. You're just comparing, one versus the other. But I'm no fan of actually cross-national comparison. So that method that Delia showed doesn't appeal to me. So we end up. So what are we left with, right? So we are then left with something similar to your incremental cost effectiveness ratio, or the kind of things. Well, I'm a professor at York as well, so where my colleagues there pioneered the concept of ICER and so on, which underpins much of NICE's own guidance, right? So the challenge for us is that this is one of several things in the arsenal for people like me. I wouldn't say this is the next best thing to sliced bread, but it certainly helps me to understand what it could be. For example, some of the questions which I'm very new to the post, so I'll at some stage sit down with both Abby and Delia, but some of the things I'm interested in more to understand is multiple intended and unintended outcomes. So that, for example, I can never possibly pick up from either the KPMG approach or even the York type approach of which underpins the NICE guidance. So there are applications, and certainly I'm very interested to see the applicability of this method. So we have under FHRI fund, the FHRI fund, 13 programs, and we can take a look at whether this approach can benefit other. Yeah. I'm not promising you more money, Delia, but certainly just in case I'm quoted out of context. But yes, we can certainly look at, jokes aside, the applicability of the program. So in some sense, how Abby delivers on this and how we can take it back to the advisory council and convince them that that's going to be very critical. Thank you.
Thank you so much, Vasan. We are out of time. Just to let you know that the webinar has been recorded and it will be available on our YouTube channel on the PCHSS, and Kaylin and Genevieve will be distributing the link to that recording to all people who registered for the webinar. So thank you very much. Thank you so much to Delia, Abby and Vasan for joining us today. It's certainly a really interesting area. And thank you very much.
Thanks very much. Bye, everyone.
Thank you. Bye.